Assalamu alaikum, everyone. Welcome to our update on the assisted dying bill session being hosted by by BIMA today. This webinar is. It's a very warm evening here, so I hope, inshallah, you have been able to cool down somewhat more than we have in Birmingham. My name is Dr. Nadia Khan. I'm a palliative care consultant and I work with BIMA on the issue of assisted dying. I'm also part of the BIMA Council as well. So I'm pleased to be with you for the next 45 minutes, where I will be giving you an update on the assisted dying bill, and it's particularly geared with regards to it providing information for healthcare professionals, inshallah. Just by way of quick introduction to BIMA, if you don't know us, then to understand what BIMA is all about, it's a membership network for healthcare professionals and for students from the Muslim faith background, and it provides authoritative advice on Islamic bioethics and health inequalities, and does lots of community-facing work as well, in-person workshops and on essential life-saving skills, which are delivered at local mosques, and other important community topics, including advice for the general public on key health issues and events, such as preparing for Ramadan, and also increasingly recently we've been raising our profile around advocacy and working on the issue of Islamophobia within healthcare settings. So that's just a quick background to BIMA. In terms of the session for today, what we are aiming to cover is a quick refresher on what the concept of assisted dying is. We will be talking about updates on developments within assisted dying and its introduction within the United Kingdom since our last webinar, which we held back in the end of 2024. So it's been a while. The issues that are at the heart of the debate on assisted dying, and what the BIMA perspective is on assisted dying as well. And finally, I'll end on what we need to do next, inshallah. Okay, so moving on to what is assisted dying. So terminology is really important when we are considering the debate and what is currently being proposed. And part of the issue is that there can be some ambiguity around the terminology, particularly when we're thinking about palliative care as it stands at the moment. So just to go over the different definitions and just to point out the key differences. Palliative care is a particular approach within healthcare, which is very well established, the UK being the forerunner of palliative care in the world. And it's an approach which aims to maximise the quality of life and to reduce suffering for people who are in the last 12 months of their life and are suffering from incurable illnesses. End-of-life care as a term tends to refer to the care that's given to a person who is in the last weeks or days of life. And the focus and the goal of end-of-life care is that it does not seek to delay nor bring forward the point of death. So it's very much about supporting that person through the natural process of dying. Assisted suicide is something very different by its nature. Assisted suicide is the idea of the provision of lethal doses of medications being provided by healthcare professionals and doctors. However, the patients themselves administer it. So the provision, the acquisition is by healthcare professionals, but the patient actually administers it to themselves. Euthanasia is where the provision and the actual administration of life-terminating medication is carried out by healthcare professionals and or doctors. Assisted dying is an umbrella term, and essentially it refers to the provisions of a means for a person to end their own life before that natural point of death. And it may be referring just to assisted suicide as it is currently within the UK. However, in some jurisdictions, such as Jersey, which is one I'll mention that's quite close by to us, assisted dying refers to assisted suicide and euthanasia. So it's really important to, again, understand and be aware of what these different terms are referring to and meaning. So since our last webinar update. We carried out a review and an awareness campaign around the previous end of life. Well, end of life is called partly end of life, but it's really the terminally ill adults end of life bill, which is referring to assisted dying being introduced into England and Wales. So this was introduced back in 2024 by a MP called Kim Leadbeater. And the idea of the bill was that it would allow those people with mental capacity to take their own life if they had 6 months left to live. You probably will remember there was a huge amount of debate and profile and awareness that took place around the bill, both by its proponents, so the people who really are supportive of assisted dying being introduced, and those who are against the notion of this being legalised. The process of going through Parliament for that bill is a staged process, as it is for any bill. So the right-hand picture shows what the actual process looks like. When a bill is first introduced, it has a first reading, so an introduction into Parliament. It then goes to second reading, where the House of Commons will essentially take a vote on whether the bill should progress to committee stage. And then at committee stage, essentially the bills should be looked at in more detail, scrutinised, debated. And then if it passes committee stage, it goes to report stage. And then a third reading takes place. And if the bill passes at that stage, then it goes to the House of Lords. And then a similar process happens. So first reading, second reading, committee stage, report stage, third reading. And then there's a potential process of ping pong where the two houses will put the bill between one another, depending on any amendments that are needed or suggestions for improvement. And then finally, it gets royal assent. So what happened with the Kim Leadbeater bill? We haven't got the time to go through all of the details of the bill, but essentially there were lots and lots of issues that were raised around the bill. And although a significant number of MPs were in favour of assisted dying in principle, so at second reading, the bill passed by a 55 MP majority. Which, if you imagine, there's roughly 600, just over 600 MPs voted on it. It was actually quite a close debate, really. And a lot of MPs wanted to sort of see what would happen with the bill in the committee stage when it was scrutinised. After the committee stage, at the third reading, it passed in the House of Commons, but by a reduced majority, by 23 out of 600 MPs. So it just goes to show how to the line it went. It then passed into the House of Lords, and they got to sort of second reading. However, because of the number of amendments that were put forward, the level of issues that were raised with the bill, it actually ran out of time in March of this year. So that bill fell. What's happened now is that the assisted dying bill, pretty much in the same format as the Leadbeater bill, has returned to the Commons, and it's being brought forward by an MP called Lauren Edwards. And she is reintroducing the bill, with the next second reading. So we're going back to the beginning of the process, happening on the 11th of September. So not too long to go. There was a lot of pressure in the House of Lords, so there was a lot of scrutiny and there was a lot of pushback as well. So politically, it became very, very difficult actually within the House of Lords, and there was, challenge directed towards specific lords and baronesses, and a lot of sharp language and sharp debate happening around it. However, we know that a very small number of MPs, if they change their mind on the bill, because essentially the Edwards bill is not different in structure, content or detail than the Leadbeater bill, a significant number of MPs would end up impacting the outcome of that bill. So we only need to have a small number of MPs who can see the issues with the bill to switch position, vote either against or abstain, and that would again create difficulty for the bill to pass. Since our last webinar, things have progressed around our particular island. So in Scotland, a separate bill was introduced because Scotland has its own parliament and constituency jurisdiction. So an MP called Leah MacArthur introduced the assisted dying bill for the terminally ill there. And this was actually defeated in March 2026 at its final vote. 69 MPs voted against it and 57 voted in favour. So again, it came very close to that point of acceptance, but ultimately MPs saw the inherent flaws within the bill and the implications. However, in the Isle of Man, which is situated between us and Northern Ireland, and Jersey and Guernsey, which are islands that are crown dependencies near to France, actually, assisted dying has gone through their parliaments and has become legalised. So assisted suicide will be legalised in both, and euthanasia, which is doctors and healthcare professionals injecting or administering medications to essentially end a person's life, has been legalised in Jersey. And services are expected to begin in 2027. So that's very sobering, I think, for us on the mainland. What have been the responses then to the development of the bill from our medical organisations and representatives? So although a number of the organisations are in principle neutral on the bill, in practice, the number of important organisations who have got direct implications created for their patient cohorts and their healthcare professionals that they are representing have come out with strong concerns. So the British Geriatrics Society has reiterated their concerns upon hearing about the Edwards Bill being reintroduced, that there are not enough safeguards for older people to particularly protect them from abuse and coercion, and that the specific complex health and social care needs of older people that will essentially be influenced or play a part in the decision making around assisted dying potentially are not being adequately recognised within the provisions and managed. The Royal College of Psychiatrists has come out again quite strongly against the bill, and they have listed a whole raft of concerns, which again we don't have too much detail to go into, but reading their report and their analysis is really interesting and again very sobering for the impact that it has potentially for the field of psychiatry, alongside the support of vulnerable people and people with mental health issues that may already be struggling with suicidal ideation. And then the RCP has also essentially put forward the practical issues that will be created by the bill being in practice. So again, they have come out with concerns raised. The BMA in its annual representative meeting not too long ago also essentially raised past motions which raised concerns about assisted dying. And they have stated that any assisted dying legislation needs to include safeguards that are currently absent from the Edwards Bill, including, importantly, recognising that assisted dying is not a medical treatment. And that changes the whole picture. When something is recognised as a medical treatment, there are obviously regulations, restrictions, permissions, which then take place and have implications for us as healthcare professionals. Protecting the foundations or founding principles of the NHS, requiring providers to opt in rather than it being an opt-out process, excluding resident doctors from formal involvement, which again is not clear from the bill, parliamentary bill, requiring nationally accredited training and requiring specialist coordinating doctors. So again, really sort of tightening the delivery and the practical application of the bill into assisted dying. So, one of the other political aspects that comes into play, which is a bit more concerning, so jumping back to politics, is the potential use of the Parliament Act in the upcoming Edwards Bill. So, because the Edwards Bill is pretty much identical to the Leadbeater Bill, if it's passed by the House of Commons, so as you'll remember, I said it's the bill sort of has started at the beginning of the process. If it's passed by the House of Commons, so it goes through second reading, committee, third reading, because it's the second successive parliamentary session in which Commons has passed the same bill, the Parliament Act could be potentially used to allow the Commons to enact the bill without the consent of the House of Lords, if it seems as if time will again run out in the House of Lords. So essentially, there's a bypassing of that scrutiny mechanism, which poses a different challenge and is of significant concern. Okay. So that's where we are at the moment. So 11th of September is the second reading date that we need to be aware of. Just for background and for us to think about what our role is within the debate itself, if we have a think about why assisted dying is being introduced as a notion, the two key arguments that are put forward by the proponents is that it's around argument one, ending suffering at the end of life, which interestingly, suffering has no mention within the bill itself. And argument two, that it's around supporting choice and control and autonomy of patients, which is how the bill is more devised and designed to be leaning on. And this is really the proponents of assisted dying, and particularly there's a campaign group that looks to get assisted dying legalized within the UK. Their promotion and the rhetoric and the imagery that's put forward in the public imagination is very much centered around that notion of choice and control, which on principle, when it comes to the idea of suffering, that may not have meaning for people in a way that it is for us as Muslims, as believers, it really can resonate for people. So the idea here in this first advert is that my dying wish is that my family won't see me suffer and I won't have to. So again, the idea of a young, vivacious person living their full life, having the ability to essentially not go through that suffering process, or even that idea or notion of suffering, and protecting family as well. So again, it's a narrative that is quite powerful and emotive for people when they're looking at it at the surface of things. Similarly, another second campaign ad that has been seen in London. So here, my dying wish is to know I have choice. My dad didn't. So again, choice, control, often a very important principle and value within UK Western society. And that, again, that idea that my dad didn't. So progress, we're making progress by actually allowing this compassionate, quote unquote, choice to become available. So these are the types of narratives and the rhetoric that the proponents of assisted dying are putting forward. What is not put forward, however, by the proponents of assisted dying is the wider consequences of introducing assisted dying into society and the ripple effects, the deep impacts that will happen through society, health, and social care as well. The introduction of assisted dying will have a significant impact on our healthcare institutional values. Obviously, when you've got a concept and a notion and a practice such as assisted dying, there will be a reorientation and a re-gearing of policy, resources, services that will need to be developed. And even up to the evidence-based development may well be skewed in the perspective of assisted dying and showing its quote-unquote value and benefit. There's also a concern that staff attitudes towards dying patients, those who are sick and chronically unwell, that may shift as well. So assisted dying, which would be on paper and in process a fairly short procedure. I don't know if procedure is the right word to call it, but an intervention, a short intervention, would be quite different to palliative care, where palliative care is about that ongoing support for sick and well people with complex needs towards the end of life. So palliative care may get reframed and seen as being quote unquote inefficient or secondary. And that notional and idea, if that's embedded within healthcare professionals, within institutions, then that obviously has an impact as well as to how conversations might be held, what implicitly might be put forward as being good for the patient at that point of decision making. There's a concern that assisted dying may lead to a degradation overall of the clinician-patient relationship. Obviously, as clinicians, our ethical foundation is first do no harm, and clearly the line is drawn. We do not kill patients. We do not harm patients intentionally. And there is a concern that if clinicians are now going to normalize that as part of the toolkit of response, medical response, that clinicians may then implicitly become biased towards giving up. And this would be a real issue, particularly for those who already have mistrust within healthcare systems and have poor experiences from healthcare. So we know ethnic communities already have less uptake of palliative care, partly down to awareness, partly down to concerns about what palliative care is about. Some people do conflate or confuse palliative care with assisted dying, even to this day. People with disability or less access to health systems because of systemic barriers, these inequalities may well be increased as assisted dying is introduced. And I've already alluded to that notion of devaluing or devaluation of certain states of life. So as assisted dying becomes normalized, then there may well be this spoken and unspoken pressure to undertake assisted dying, where certain types of life are not seen worth living. And therefore, there's that internal pressure to not be living in that state. Not feeling like you've got adequate support, or the people around you are, affected negatively because of your existence, the way things are. And so people who are particularly vulnerable, people who have got adverse social circumstances or feel like a burden to others are particularly at risk of internalizing that pressure. And a general erosion of compassion. Again, it comes back to that notion of some lives are not maybe worth living, and actually, can we extend compassion and care to all, regardless of their situation and their health as it stands, and what they can give back to society, how productive they are. So there's a lot to it. I think reflecting as Muslim healthcare professionals, even though obviously we have from a faith and ethical standpoint, on principle, we will have an issue around assisted dying either being within direct practice or impact on ethnic minority or faith communities. Actually, the issue is so much broader than that, and part of our ethos and our ethics as Muslim physicians is that we do have a duty of care to speak out for the public good, for those who are vulnerable within society, for those who are ill. This is part of our tradition to advocate and to support and be healers more broadly. So this is really where us as Muslim healthcare professionals need to see this as an issue that we have to contribute to and have something useful and important to add. In terms of the practical professional concerns with the bill, so I've talked sort of more broadly around kind of ripple impact for society, but there is a plethora, there's a huge list of different practical professional concerns with the bill. Once you start to analyze the bill and think about implications and consequences, it becomes quite overwhelming. But just to kind of point out some key issues, which are kind of quite surface level, but are immediately obvious. So the bill is looking at people who've got 6 months, less than 6 months to live. So number one problem, it can be so difficult to predict when death is near. We know particularly, so from the palliative care perspective, although in the cancer trajectory of deterioration, it may be somewhat predictable. I say somewhat. In conditions such as organ failure, end stage liver disease, lung disease, heart disease, it can be very, very difficult to predict. And in frailty and elderly related age issues, it can be even more so difficult. And I know from practical experience working in a hospice, we may at times have patients who are transferred over to us for end of life care from the hospital because they genuinely look as if they're coming towards the end of life. However, when they've reached the hospice and they're provided with the palliative care support, attention to detail to their holistic needs, the higher level of nursing ratio, which means that nursing care is delivered, while actually their prognosis can look a little bit different. So people may not be as end of life as what they might appear. And that's people who are right close towards the end of the life. So 6 months away it's really, really difficult. There's no way to, accurately predict that. It can be quite difficult for healthcare professionals to ensure a person has mental capacity. And for those of us who do undertake mental capacity assessments, particularly in patients who have got either borderline issues or complex medical conditions or complex social conditions, that can be very, very difficult to be able to say definitively. And often you might need to get input from other MDT members, etc. So to be able to say that people have mental capacity to undertake assisted dying may be challenging in a number of different folks. And I think importantly, it's difficult for healthcare professionals to assess that a patient's not being coerced. So coercion is a very difficult concept and component, I think, to fully be able to tease out with patients. We do try our best, of course, with that, and we will, from a holistic perspective, look to see whether there are any particular pressures being applied, etc. But you never quite know what's going on with a patient and the sorts of pressures that might be being applied, which are quite invisible and not obvious to healthcare professionals, particularly if you don't know that person well, or you've got very limited time to speak to them, or it's a one-off assessment and you haven't got that continuity of relationship or understanding of their social dynamics, etc. So again, it's a really difficult area to be able to have certainty in. And I've already alluded to the ethical concerns. Fundamentally, it jars against the professional purpose of medicine. And that poses significant challenges, changing the ethos of medicine in such a huge paradigm shift. Many healthcare professionals will be indirectly involved, even if they don't want to be. So this is another real challenge. Although on the surface of it, the bill states that you can opt out and you don't have to take part in undertaking assisted dying, which obviously ought to be the case. But actually, you do need to be able to signpost on to ensure that that person has access to quote unquote care. So that still is quite grey and it's not been clearly defined. And that's another real sticking point that we need to work through, and it's being looked at closely. We have to learn from other jurisdictions and the experiences that they've had, and there are concerning themes coming out of particular countries, notably Canada. Increasingly, physicians are raising the alarm and people within society are raising the alarm around the implementation of what they call medical aid in dying, MAID, which is both assisted suicide and euthanasia. And I'm just presenting a quote here from Dr. Johnston back in 2019, where he raised alarm that few Canadian doctors foresaw that going neutral would guarantee the arrival of euthanasia. or that promises of a shot in the arm, so support for developing palliative care, would be forgotten. Even fewer realize that they would have no option but to cooperate with providing death on demand. It has become all too easy to end patients' lives. And that was back in 2019. Things have progressed since there, where now actually formally concerns are being raised within different states around MAID and how it's having an impact on population. We're seeing the trends that there's increasing percentage of deaths happening due to assisted euthanasia, suicide and euthanasia in the countries where it's legalized. And we're also seeing that the reasons for assisted dying do end up getting widened over the time. So although initially jurisdictions bring in quite a tightly controlled or defined kind of bill or parliamentary approval for assisted dying, then challenges are brought to that bill in terms of access to other groups that ought to be allowed or enabled to receive quote unquote compassionate care. So assisted dying has been widened out to those people who have chronic illness. So not just those who are terminally ill, actually chronic illness can be a reason to request assisted dying. Psychological reasons are now a reason to request assisted dying in some jurisdictions. And it has been extended to under 18s and children in one European jurisdiction as well. And there's other kind of increasing access measures that are being undertaken with bills across the world. So a number of bills have got sort of reflection periods built in as kind of safeguards. Those are being removed in view of quote unquote efficiency and again improving access. So there's lots going on, and there is increasing concern about coercion as well coming out within different media. From the assisted dying issue, a BIMA perspective. So as BIMA, we're very much putting forward the notion that every life has equal worth, and that compassion means that we respond to those who are vulnerable and weak with increasing care and mercy. That's really important for us in terms of our ethical and foundational purpose as Muslim healthcare physicians. The measure of a compassionate society shouldn't be seen by how it treats the strongest, but how it stands and supports beside those who are the weakest in society. And as I say, that every person's life has equal worth, regardless of illness, disability, age, dependency, cognition. That principle is a red line. It must never change. We need to build a society and healthcare that supports everyone, and it should be a space where nobody feels that their death is a kindness. So no one should ever have to wonder whether they would be doing their family or society or their carers or the healthcare system a favor by dying. The answer to being dependent should never be death. Our responsibility is that we remove the burden. We don't remove the person to resolve the situation. Finally, the laws that are regulating medical practice need to protect those with the least power. So good laws are not judged by the easiest cases. They're not judged by the sort of cases where it's, emotive suffering and that person is able to put that powerful narrative forward that is compelling, emotionally compelling to those hearing it. That's not the way to make good law. Good laws are judged by how well they can protect people who are frightened, isolated, disabled, feeling like a burden. And particularly when this decision can't be reversed, the safeguards have to protect everyone, not just those people who have the loudest voice. So that's the sort of BIMA position on assisted dying. We've held to that from the beginning, and we continue to work with coalition partners and organizations who have got a similar goal to try and put forward that notion of compassion being the appropriate response to people who are suffering and in distress, and particularly the notion that we need to have good palliative care that's accessible and available for all, because at the moment, fundamentally across the UK, there is such wide there's such wide variation in access to care, high quality palliative care. How can we then say assisted dying is a true choice when you don't have the choice to be able to access good support? So that's the sort of key point that we're raising. So we need your help with that. It's not something that we can do alone. It's really important that as healthcare Muslim professionals in particular, we are raising our voice and taking an active interest and participation in shaping the debate. So it's really important that we spread the word around the changes that are potentially being discussed and will potentially be implemented. It's important to share information with our wider social networks, with masajid and community centres, so that the community is aware of what's being discussed and what's being put forward by their representative MPs. It's important to try and understand the specifics of the bill, because the devil really is in the detail. And although you'll hear a lot of rhetoric, which is very emotionally compelling and heavy, actually the details of the bill are the problem. They are the issue, and this is why we really need to understand that in better detail. And there's lots of really good resource out there, which I'm going to signpost to if you want to take that deep dive. It's important, if you can, to try and contact your MP. So the MPs, fundamentally, this is where the decision will get made by the MPs according to how they vote on the issue. So it's really important, if you haven't already, to consider contacting your constituency MP. As a healthcare professional, your voice is really powerful. So it's important to ask for better safeguards, better funding for palliative care, and accountability as well for any end-of-life legislation. And finally, we are joining a coalition against assisted dying. There will be a protest that's happening on the morning of the second reading, 11th of September, in Parliament Square. And we would absolutely love it if, alongside our partner organisations, including disability representatives, that we are able to present and make that case for our concerns around assisted dying. If you are keen to speak to your MP and would like to kind of take that issue forward to them, I would say please do. Your voice is very powerful on this issue, and the MPs do want to do the right thing as how they see it. And most of them do not understand the nuances and the details of the bill, and particularly what the implications are. So that's where highlighting those is really, really important. And if you are planning to see your MP, now is the time to speak to them, ring the MP's office and make an appointment so that you can get a slot before the second reading. Focus on three key concerns if you go to see your MP or issues. You won't have time to cover every single minutiae detail, but particularly if you understand what your MP may be swayed by or has particular concerns about, you will be able to then kind of tailor what your suggestions or your feedback or perspective is, so that you can have a fruitful discussion with your MP. And it's important to illustrate your concerns with professional or personal stories if possible, whilst obviously not broaching confidentiality around patients. Okay. So just in terms of resources, our work is not finished, it's ongoing. We need to continue engaging on this issue. We've got lots of resources on our website where there is a link. You can go on to the generic British Islamic Medical Association website and just search assisted dying and it will all pop up. But we have also got a WhatsApp broadcast list where we will post any important updates. So if you are interested in just sort of having information fed to you, please consider joining the WhatsApp group. You can scan in the QR code there and it will take you there directly. And also British Islamic Medical Association will be running an email campaign as well. So we've got an email tool set up on our website and you can go there, click on the link. It essentially provides you with a template and identifies your MP. So it makes writing to your MP very easy as well. Our partner organisation, Our Duty of Care, is also really helpful in terms of resources. They've got briefings on the bill, and they've got a template letter which could be utilised for speaking or writing to your MP. Okay, so please contact your MP within the next few days if you are planning to speak to them directly. And if you plan to write, then think about using the BIMA email campaign tool. And please consider joining us at the protest in Westminster on the 11th of September. Sister Naomi, who's our policy officer, will be there, and inshallah, I hope I will be present as well. So would love to see other people joining us as well, inshallah. If you are planning to join, then just drop us an email. Okay. Jazakallah khair for your time. I know it's 8:45, so bang on end of presentation time. However, if anyone has any questions which would be helpful for me to answer, I'm very happy to do so in the next sort of 2, 3, 5 minutes. So I am going to see if there are any questions. Naomi, if there's anything in particular you want me to answer, just let me know.
Yeah, so we've got one here. It says, what does the Islamic jurisprudence say about stopping the active treatment and starting patients on anticipatory medications as part of the end-of-life treatment?
Yeah, so there is essentially Islamic jurisprudence allows palliative care. So when it's clear that that person is essentially dying and there is a lack of reversibility to their underlying illness, it is permissible to use anticipatory medications and provide end-of-life care. That's a very summary answer, but if anyone's interested in more detail, again, Al-Balagh, which is an institute that a scholar, Dr. Rafaqat Rashid, is heavily in the leadership of. They've done a very nice fiqh off end-of-life care program. So if you were interested in the details or a deep dive, then I would recommend them. Any other questions?
Nothing more. There's another one there. Sorry. Is there anything in the bill that would protect those providing the service from being pressured by hospital management?
It depends what you mean by pressure. The short answer is no, in the sense that if institutionally services have to be developed and built. So, for example, as leadership, you may need to be involved in resource allocation for assisted dying, or service development, or creating pathways, etc., that sort of thing. So even though you wouldn't necessarily have to undertake the direct act of assisted dying, there may be pressure to be able to provide that service in other ways, and that's a challenge. Okay. There's no other questions, so I'm going to let everyone disappear because it's very, very warm here as well. But Jazakallah khair for attending. I hope that's been useful, and inshallah, please do engage on the topic, and we would love to see you outside Westminster on the 11th of September. Please do join us on the WhatsApp list as well if you'd like to keep up to date. But appreciate your time, and inshallah, we'll see you again soon. Assalamu alaikum.